Hello, everybody. Welcome. This is a first for us. This is a workshop where we hope that you will get the answers for how to motivate your staff or yourself, or if you are staff, how to feel motivated, how to get those questions answered about the vaccine. We have our speakers today, Dr. Biana Roykh, who is the Senior Associate Dean for Clinical Affairs at Columbia University College of Dental Medicine, and also Dr. Magdalena Sobieszczyk, who is the Chief of Infectious Diseases and co-chair of the COVID-19 Vaccine Committee at Columbia University Irving Medical Center. The two of them will address with us crucial conversations on how to motivate your staff to get vaccinated. But right before we get started, I'd like to welcome our president of New York County Dental Society, Dr. Lois Jackson. Dr. Jackson's just going to have a few words, then we will jump right into the lecture. Dr. Jackson.
Hello, everyone, and we're so glad that you're joining us this afternoon for this crucial conversation that came to be because I was having the same conversation with my staff. And I thought that if I were having this conversation, then there were many people who were having the same conversation, and that New York County Dental Society was the place to provide you with this so that you could take it back and use it right away. So we are so happy that these doctors have agreed to speak with us today. I have a soft spot in my heart for Columbia since I'm a graduate, and they are here from Columbia today. So without further ado, I want to say one thing. If you appreciate this information, this crucial conversation, please come to our website and make some sort of donation. We are in need of every donation. We look forward to providing you with more crucial conversations, and we hope that you'll enjoy this afternoon. So without further ado, thank you so much for being here today. And doctors, please go right ahead.
Well, thank you so much for this warm welcome and for membership for inviting myself and Dr. Sobieszczyk to speak with you about this very important, relevant topic of 2020 and 2021. Today, we hope to accomplish with you a couple of things. We would like to recap the vaccination efforts that are underway. We'd like to pause and speak a little bit about the side effects that we're seeing related to the vaccine. We'd like to talk a little bit about the considerations around policymaking on making the vaccine mandatory versus recommended. We'd like to talk and focus on uptake in the community and with your staff and recommendations on how we can encourage everyone in our community and our practices to get vaccinated. And we'll spend quite a bit of time on commonly asked questions related to the vaccine that we've received from membership and that we're also managing here at Columbia with our own community around fertility and pregnancy considerations, around underlying health conditions and how they may be impacted by the vaccine, also around prior COVID infection and how that may be influenced by the vaccination efforts, among other questions. So we have a packed agenda for you. We'd like to keep it somewhat informal. Susan is monitoring the chat. So if you have some questions in the chat, she knows to interrupt us, and we're happy to pause and answer those questions. But we will also leave some time in the end for participants to ask questions. So a little bit about the COVID impact. I know a lot of you are watching the news and glued to the TVs, trying to keep track of what's going on with the infection. To date, there are about 95 million cases reported. Worldwide death rate is at about 2%. In the United States, it's at about 1.7%. And in New York, because as you know, we were hit so hard early on with the pandemic, we have a reporting of 1.26 million cases with about 40,000 deaths. As of Sunday in New York State, there were 13,000, a little bit over 13,000 active infections going on in the state. So indeed, we are in the middle of a resurgence yet again. You can see the curve moving up, and of course, monitoring all the trends. So getting vaccinated now urgently is a critical conversation. What we know about the vaccines in the United States, there are two, Pfizer and Moderna. They're both mRNA vaccines, and Magda is going to spend a little bit of time talking about what that technology is. The main difference is that Pfizer is recommended for 16 years versus and over, and Moderna is for 18 years plus. There are studies going on right now around vaccination impact in children, and hopefully as the year goes on, we'll get more information about the use of the vaccines in minors. Both vaccinations are 2 shots in their delivery, and the only difference is that with Pfizer, the 2 shots are about 3 weeks apart, and with Moderna, they're about 4 weeks apart. The studies that were conducted with the 2 vaccines allow for about 4-day wiggle room on either end with the second dose, although the recommendation is that if for some reason you miss that window, that you continue to come back and receive the second dose, even if you missed the 4-day window. It's just that the studies were done with this window in terms of effectiveness. Both vaccines are reported to be very effective at preventing symptomatic COVID disease. And Magda will spend a little bit of time talking about that next.
Next slide. Great. So let me dive into a little bit more detail about the mRNA vaccine. So this is a busy slide, but we wanted to show this to you because I kind of wanted to make a few points. First of all, just about the kind of, have to do with the safety and effectiveness or efficacy of these vaccines. So just a very brief review about how these mRNA vaccines work, or messenger RNA vaccines work. They essentially work by presenting your body with a small set of sort of genetic instructions for producing the SARS-CoV-2 spike protein. So it's just kind of the genetic code for the spike protein that's on the surface of the virus that gets included in the vaccine. There is no live virus in the vaccine. The body makes the protein and presents it to the immune system to teach it, kind of to sort of show it what the protein looks like, so that the immune system can recognize this protein should it ever encounter the actual COVID virus. And it sort of prepares the immune system for an immune response to keep people from getting sick. This essentially involves making antibodies. So the immune response is making antibodies to this spike protein and making also T-cell responses. So a couple of things: that this mRNA is very short-lived and easily degraded. So it's very fragile. So it's sort of encased or enveloped in a lipid particle. Also, that's why it must be stored at cold temperatures during storage. Once the vaccine is injected into the arm, the body just uses the instructions to make the spike protein, and then it rapidly breaks down the small amount of the mRNA that's remaining. So leaving kind of no permanent trace. The vaccine, the mRNA, does not enter into the nucleus of the cell, and it doesn't change the human DNA and cannot cause any genetic changes. So a couple of, again, points to highlight: that it's impossible to get COVID from the vaccine because there's no live virus in the vaccine. There have been, sort of no cases of any death caused by the vaccine itself. It's also important to keep in mind, and also important to keep in mind that the protection from the vaccine is not immediate. It takes some time for the immune response to build up. So while after following the vaccine, and we'll talk about this later, you still have to kind of follow the usual precautions of wearing face coverings, avoiding social gatherings, staying away from crowds, and keeping sort of distancing as advised. Next slide. So let me talk a little bit about kind of what does it take essentially for a vaccine for these, what did it take for these vaccines to kind of get to this emergency use authorization, what we have right now for both of these vaccines. So this is really a very specific circumstance that the FDA gives the emergency use authorization for anything during a pandemic. It's a mechanism to kind of speed up the availability and use of medications or vaccines during a public health emergency. And the FDA stated very early on that it will hold the vaccine studies to a very high standard, and that a vaccine in a phase 3 trial has to be at least 50% effective in preventing COVID illness, and that they would need to see at least 2 months of safety data following the second dose. And they would need to see it in at least, half of the people in the study before they would consider giving the emergency use authorization. So the FDA sort of, convened advisory committee on immunization practices to kind of review all the evidence. They themselves reviewed all the data from these studies before granting this emergency use authorization. And importantly, kind of long-term safety is monitored by the CDC and the FDA through these mechanisms. One is called vSafe, where it's actually everybody who got a vaccine is encouraged to sign up for it to kind of report any side effects from the vaccine. And then this system called VAERS, which if there are any side effects reported from the vaccine, that gets sort of channeled to the FDA and the CDC. Because all of this information is important for the granting of the kind of the full licensure of the vaccine that will follow in some months. So important to keep in mind that even though everything happened quickly, the COVID vaccines were kind of being held to the same safety standard as all vaccines. None of the steps in the testing of the vaccines were skipped. There were just all the phases of the testing were overlapped because so much public resource and private and public resource were poured into the development of these vaccines. And manufacturing of the vaccines actually started even while the studies were ongoing at some risk to the sponsor, but in order to kind of make sure that this is a smooth process or as smooth as possible. Next slide. So these are just a couple of notes about what the vaccination efforts to date have been, both sort of US, there's in terms of how many people have been vaccinated, and these are data through the weekend. So at least 3.2% of the population have received the first shot. A little bit less than 1% have received both shots of the vaccine. In terms of the doses distributed, you can see the numbers here. In terms of looking kind of at the experience from the New York State specifically, looking at the COVID-19 vaccine distribution dashboard. So there have been, over 700 sort of 1,000 doses that have been distributed, that have been administered as of this weekend. And essentially just kind of a point to highlight that about 72% of the doses that have been received by New York State have been administered as a first dose. And then about 65% of those doses that have been received by the state, they've been administered as a second dose, which essentially just means that people are coming back for their second dose. The second dose is being administered quite smoothly. People are doing sort of tolerating it fine and coming back for their second dose. Next slide. And then just kind of to share with you some of what we've been seeing here at the Columbia community in terms of our local experience with reported reactions. Most common ones are just soreness, tenderness at the injection site. The next most common one is fatigue, headache, muscle aches, joint aches. Fever is actually less common. We've noted, and this has been also described in the clinical studies, that reactions are more common with the second dose. But for majority of these effects really last no longer than 1 to 2 days, and they can be relieved either by Tylenol or NSAIDs, but really have not been incapacitating and just diminish quickly. As with any medication, allergies or vaccine, allergies can be seen, but this is still a rare event, even with the COVID-19 vaccines. Next slide, and I'll hand it off back to
So
Biana.
there's been a lot of questions about, well, why can't we just make this vaccine mandatory in our practices or in our places of work? And, therefore the uptake will be, more enforced and we can move on with our lives. There's a lot to consider in making this decision. Yes, practices can definitely consider making this vaccination mandatory as condition of employment in your dental offices. But at this point in time, there's a lot to consider with making such a decision. There are legal implications, and we would encourage those of you who are considering that to consult with the practice attorney about taking this step in your practice. If you do take this step, it's important to be able to manage exceptions. As you have seen, the vaccine has not been studied in persons with immunocompromised conditions, and we'll go over those recommendations, but there may be a subset of persons still waiting on additional time and clarification around the appropriateness of vaccine for their unique conditions. So being able to manage exceptions is going to be an important consideration. Also being able to manage the fallout of making it mandatory. If an employee decides that, they just refuse to take it, they don't feel comfortable, they for some reason are not ready to take it, would you consider this grounds for termination, given that it's a mandatory policy in your practice? And one would have to be prepared to manage such a situation. Given that we're still in the emergency use authorization phase of the vaccine, timing is very important in making this decision between mandatory versus recommended. At this point in time, even here at Columbia, the vaccination is strongly encouraged and strongly recommended. There's a lot of effort on the ground to uplift and improve the uptake of the vaccine among our staff members, but it is not at this point mandatory. And while at some point, we can expect that it might become mandatory, practices making this decision today should be mindful about the current climate. The other impact is the morale. People get sensitive about somebody dictating something that really impacts their own health. And so making this decision as mandatory could potentially have some effect on the morale. So if, like many practices, your practice continues to keep it as a recommendation for staff, what can we do to help encourage the uptake? And we'd like to share with you some tips that we have adopted here at Columbia, and hopefully they will be also applicable in your practices. The first thing is to lead by example. It's very difficult as a dentist, dental practitioner, to recommend for somebody to go get a vaccine if you yourself have not signed up for the vaccine. It really is, as leaders, all about what we do and much less about what we say. And so leading by example and being, having the doctors in your practice, the hygienists in your practice, pursue vaccination really helps to show staff that you're in it together and you're out there really adopting and accepting this important public health measure. We want to make sure as practitioners to help our staff locate places to get vaccinated. As you know, we are in that first priority phase as direct patient providers, and our staff are prioritized, but it's not always easy to get an appointment or get to the location. And so anything that we can do as leaders to help our staff find a place to get the vaccine is important, and making it easy to access for them. If it's an appointment that's during the day and you have to give them time off during the workday to go and get vaccinated, you doing so really speaks volumes to the staff, letting them know that you find this to be of extraordinary priority and you're making time during the workday to support them to go get this vaccine. You want to be able to provide resources and information for staff, and we will share some of the resources with you that you can definitely point your staff to get good, reputable information, and being really open and listening to the staff about any concerns that they might have with the vaccine, and continuing that conversation with them if it takes more than one conversation. You should be relatively prepared to speak on some of the best practices about the vaccine and keeping yourself current with any trends or new information that is coming out about the vaccine really helps to set the tone of, knowledge, competence, and trust. And hopefully your relationship with the staff, plus you staying current about best practices, helps to leverage encouraging the team members in your practice to pursue to get the vaccine. Some other things to think about is incentives, and you have to consider the fallout of those as well. There's positives and negatives with incentives. You might want to encourage people to get vaccinated, and as a result offer maybe a paid day off, to celebrate their commitment to taking care of themselves. When doing things like incentives, you want to really think about whether you make them individual or if it's a team-based incentive, everybody goes in to go get the vaccine, and multiple considerations need to be made if you make the incentives either individual or team-based. You don't want to be in a situation where you end up impacting morale of the office or putting people under severe peer pressure to get the vaccine, because it could take individuals some personal time to accept the new public health measure. So really reflecting on the culture of your practice, knowing your people, talking to your people, being open, patient, available, coming back to those conversations if necessary multiple times is what we find to be one of the best ways to help encourage the uptake of the vaccination. There are many commonly asked questions that we've had to navigate here at Columbia, and we've also received through membership questions prior to this workshop that we'd like to go over with you today. The first one relates to pregnancy and fertility questions, and Magda's going to speak to some of those.
Great. Thank you again. And before I dive into the pregnancy, maybe I'll talk a little bit about just what do we know about the safety and efficacy of these vaccines in individuals who've had prior COVID-19 infection. So what do the data from clinical trials tell us? And then I'll kind of focus on some key questions that come up a lot. So just a couple of things to clarify that even though in the Moderna and the Pfizer BioNTech studies, one of the exclusion criteria was documented prior COVID infection. So those individuals were excluded. There was, however, a certain small but very important number of participants who at enrollment had on further testing had either a PCR positive for COVID or evidence of previous infection with positive antibodies. It was sort of unbeknownst to them. They were enrolled in the study, they were followed, and there were absolutely no differences in vaccine safety and efficacy based on prior infection. So if someone, I oftentimes get a question, I had COVID back in May or April of last year, should I take the vaccine? And the answer is yes, that clinical trials of these vaccines included individuals with prior COVID illness. And there, again, as I mentioned, no differences in effectiveness, efficacy and safety, and you should proceed with getting vaccinated. And then the follow-up question could be, well, do I really need a vaccine if I had infection in the past and I have antibodies now? And the answer to that is yes, vaccination should be offered regardless of history of prior infection. And that is because duration of natural immunity, immunity following natural infection, is really unknown, and it varies from person to person. It's very variable. So what you're trying to do with a vaccine is just sort of deliver kind of a consistent level of immunity, so to speak, in terms of making these antibodies so that everybody is kind of protected in a uniform fashion. And we know that even though kind of natural immunity following infection may happen in the short-term period, like in the first 2 to 3 months, reinfections can happen after some time period. So in order to kind of to get that more lasting protection, vaccine is needed. Another common question that comes up is, what if I got my first shot and then I'm scheduled for my second dose in a couple of weeks, but my COVID test just came back positive in the interim? Can I still receive the second dose? And the answer is yes. Just wait to be vaccinated until your home isolation or home quarantine is completed. And then the second dose really should be given as close as possible to the original date of the appointment, as Biana sort of mentioned, in terms of kind of the dosing intervals. Next slide. Great. So another sort of common kind of questions, and this again pertains to safety and efficacy of vaccine, is, how generalizable are these vaccines to individuals and communities around us, specifically those with people with certain underlying comorbid conditions. So let's take a look at a couple of some key questions that come up in this context. So one could be, I have asthma, I have type 1 diabetes. Is vaccine safe and will it work in someone like me? And there's actually sort of nice data to document that, yes, the answer is vaccine appears to be sort of safe and well tolerated and effective. And there are no contraindications for people with asthma or diabetes. And in fact, we know that in these, the Moderna and the Pfizer BioNTech studies, there was, up to 22% of individuals who had some underlying medical conditions, such as diabetes, heart disease, chronic lung disease, liver disease. These are, again, also individuals who are at higher risk of more severe COVID. So they would greatly benefit from being vaccinated. And a little bit less than 10% of individuals in the studies had asthma. So we know that the vaccine was sort of well tolerated in them, and it was efficacious in that group as well. I do want to point out that even though there are some limited data on individuals with immunocompromising conditions, there was a number of individuals, but a small number with HIV infection and malignancy included in these studies, and they tolerated the vaccine well, but it's not as robust data as for the general population. These individuals are still encouraged to get vaccinated if there are no other contraindications to getting the vaccine. Next slide. So now let's dive into sort of the issue of pregnancy, because that brings up a lot of questions, both related to safety in terms of taking the vaccine during pregnancy and whether or not vaccine can affect fertility, either in men or in women. So, current recommendations, and this comes from the CDC and also the American College of Obstetrics and Gynecology. So the current recommendations is that individuals who are actively trying to become pregnant or contemplating pregnancy and meet current criteria for vaccination, they should get vaccinated. And why? Where does that come from? And this really comes from some of the data that I mentioned, kind of about how these vaccines work. So these vaccines are not thought or not believed to cause an increased risk of infertility. They don't contain a live virus. They don't enter the nucleus and do not alter the human DNA and cannot cause any genetic changes. Again, the mRNA also degrades very quickly and is gone from the body in a matter of days. And there were some kind of rodent fertility studies that were done with the Moderna vaccine that were presented to the FDA, and there were no concerns seen in terms of the kind of animal studies, which are sort of classically done for all agents to look at fertility. So there are no concerns on that account. In terms of pregnancy, individuals who are pregnant, even though there are no safety data that are kind of specific to use of these vaccines in pregnant individuals, the current recommendation is not to withhold the vaccine from those individuals if they meet criteria for vaccination. And it's really very much kind of an individual choice, and an individual may want to consult and sort of discuss it with their OB-GYN provider and sort of talk about the risk and the benefit. And if there is a risk of COVID infection through work exposure, through other exposures, the vaccine people may choose to take it. And there have been pregnant individuals during the rollout who've elected to get the vaccine and has been tolerated well. In the Moderna and the Pfizer vaccine studies, pregnancies happened, just like life happens during the lifetime of a study. And there have been no adverse outcomes from individuals who became pregnant while on study. Follow-up continues, so there will be important data that will be coming. But take-home point is that because pregnant individuals are at an increased risk for severe illness from COVID-19, the vaccine should not be withheld from them if they meet criteria for it. And it's very much an individual choice, and it can be a conversation with our provider. Next slide. And here's just a list of resources we're kind of highlighting here, resources for providers and also for staff members and for your patients maybe even. And the CDC has some facts on COVID-19 vaccines and a good kind of questions and answers. The New York State has a good resource also. And then the Pfizer and Moderna emergency use authorization fact sheets, both for providers and for patients, actually also kind of full of pretty quite good information. It's a good resource. Next slide.
Some of the other questions that we have received is, if I live with someone who's not yet eligible to receive a vaccine and I receive a vaccine, am I putting, my loved ones at risk?
Yeah, that's a great question. And I think, the kind of a key thing to highlight is that, you cannot get, this COVID vaccine the COVID vaccine doesn't cause COVID, doesn't, so you cannot, actively pass it on to someone else. However, one thing that sort of remains an issue is that even, after you get vaccinated, we know that the vaccine prevents symptomatic illness and severe disease. We don't have full information about whether or not it prevents asymptomatic infection. So for that reason, you should still kind of maintain the usual precautions that we're encouraging everybody to take in terms of wearing face masks, social distancing, and doing so until everybody gets vaccinated. But kind of key thing to highlight that even without being vaccinated, many people are asymptomatically infected with COVID, and therefore it is still beneficial to be vaccinated to prevent severe disease. So vaccine doesn't sort of cause additional sort of infection, doesn't increase the risk of getting infected, and doesn't increase the risk of transmitting it to others.
There's a question in the chat. Can we expect an initiative to get dentists and staff vaccinated in New York City? Currently, our staff aren't able to get appointments scheduled. I believe I believe that everybody who's patient-facing is currently eligible to receive the vaccine. Dentists are included in that group. The Department of Health, I think, is managing some of the sites, and I know that there are clinics that do offer appointments. It's not always readily available to receive the vaccine, but appointments are periodically released as the vaccines are delivered to the city. I would encourage to keep checking the New York State guidance and website about locations where vaccines are administered to frontline workers.
Mm-hmm. Biana, and I see another question. I can take that one. If it's okay to take ibuprofen or Tylenol prior to the second dose, just to kind of blunt that as I sort of mentioned, that some people are reporting some more kind of local side effects. And really, the recommendation, the official recommendation is not to pre-medicate just because of some theoretical concern about maybe blunting the antibody response. I think the data for that are quite conflicting. I can tell you sort of from reviewing the literature, but I think the official recommendation is that, you don't want to take any chances in terms of modulating the immune response. So official recommendation is not to take Tylenol or ibuprofen, but take it sort of following the dose the moment you sort of experience any side effects. And we tell our colleagues to do that, just exchanging texts with my colleagues who got vaccinated yesterday or the last couple of days. And they, some of them took a little bit of Tylenol just following the vaccination.
There's a question about what does the vaccine prevent? Vaccine prevents symptomatic COVID infection.
So kind of essentially someone from, it's kind of that moderate illness that then and hospitalization. And the reason we don't know precisely and for sure whether or not it prevents asymptomatic COVID is because the studies were not designed to essentially serially swab people, right? Because that's the way you would sort of find out if you're preventing asymptomatic infection. You test everybody, regardless of whether or not they have symptoms. There is some evidence, early evidence, that the vaccine does prevent asymptomatic infection, but those studies are ongoing and kind of so firm data will be coming soon. So for now, we're sort of saying we don't know for sure if it prevents asymptomatic infection. We know it definitely prevents symptomatic illness, prevents hospitalizations, and prevents death. But until we have more data, wearing the masks, social distancing, that's all important, and getting everybody up and vaccinated to build up the immunity.
There was a question in the chat earlier about management after infusion and how that relates to vaccination. Maybe we can discuss that a little bit.
Yeah, infusion of antibodies, Biana, is that
Correct.
right? Yeah. So that's a great question, because I spent some time talking about how after natural infection, you just come and get vaccinated. But what about if someone had COVID, right, and got monoclonal antibodies or convalescent plasma for that matter? So the current recommendation is to wait like 90 days or 3 months following that infusion of those antibodies. And the reason for that is that, with the infusion of antibodies, you're kind of getting a large dose of antibodies, more than you would naturally in kind of your immune system would generate. So the thinking is, just to sort of not to cause any interference between the antibodies that are kind of dissipating and the ones that are going to be boosted by the vaccine, just to let some time pass. And again, thinking that within those 3 months following the infusion, you're protected, you're unlikely to get reinfected. So wait to get the vaccine for that time period. And as recommendations may change in the future, and if so, then we'll adjust. But for now, that's the state of our data of what we know.
There's a question about vitamin D and if it's okay to take vitamin D around the same time as the vaccination injection.
Yeah, so that's a great question, and I know there's also a lot of kind of interest in trying vitamin D for even kind of treatment of COVID, early COVID, and there are really no data to substantiate that other than kind of from some retrospective reviews. I don't see any, I think it depends a little bit like how much vitamin D you want to take. I think kind of regular amounts are perfectly fine to take, just because there may be some added benefits sort of that's kind of in terms of other health benefits. I don't see any reasons not to, but I also wouldn't I wouldn't recommend it sort of as something that everybody has to do in order to sort of boost an immune response.
There's a question about Governor Cuomo announcing that there's some concern that the vaccines are not as effective or effective against the new strains, and whether we have some comments. I mean, certainly, even if the virus is mutating, we know that the vaccinated body is going to be able to mount some level of immune response. And even if you were to come down with symptomatic COVID as a result of the new strain and the unknown that we have yet to learn about, it's likely that because there are elements of the original strain that you've been already vaccinated against, that the body will be able to mount a more appropriate response and likely reduce the chance of severe illness and hospitalization.
Yeah.
Would you add anything else?
Yeah, no, I agree. And one kind of key thing to highlight is that yes, there are sort of concerns about the new variants of COVID, which is actually, not surprising that the virus mutates. And I think, and that it's, easy, and this one, there's sort of information to suggest that it's easier to transmit, which is yet why it's incredibly important to kind of continue wearing masks and practicing kind of these social distancing measures, because that's a sure way of preventing transmission. And then with vaccine kind of as an, added on top of it, it just limits the ability of the virus to be transmitted, to be replicated, to mutate further, and kind of so both the vaccines and the face masking are kind of critical in dampening the spread of any viral variants. but a lot of research is taking place on to understand exactly what is the impact of these new strains on natural protection and vaccine protection and monoclonal antibody-induced protection. So a lot of work is going on as we speak.
Certainly that there were some claims made, but they haven't been confirmed about, Moderna having a longer lasting effect, immunity effect. Those claims have not been substantiated. We don't have the evidence quite yet. So a lot remains to be learned about the long-term effect. We know that the flu vaccine obviously gets updated annually and has to be administered annually as a result of the mutation rate. There's a question about the Moderna vaccine effectiveness, and the Moderna vaccine is rated as 94% effective and Pfizer is at 95%. And the question is, what happened to the other remaining percent of individuals?
Yeah, so it means that they may have developed an infection, but it was sort of substantially lower in the vaccine group than in the placebo group, and then the infections were also milder. So there was no severe cases of COVID in the vaccinated group. But yes, a small proportion of individuals, even after the vaccine, developed it, but substantially smaller than in the vaccinated group, and substantially sort of less severe and milder.
And important to note that there have been no reports of death associated with the administration of the vaccine. Those of you who have gone to get the vaccine or maybe have heard about the process, persons are carefully monitored for 15 minutes to 30 minutes after the administration of the vaccine. That's usually the amount of time that if somebody were to have sort of an anaphylactic reaction to the administration, which is one of the most significant side effects that we're concerned about, that it would be obvious in that first 15 minutes to half an hour. Up to 4 hours is when that anaphylactic reaction could mount. But the first 15 minutes are critical. So all the vaccine sites are set up for that monitoring following administration. There's a question between the substantive difference between Moderna and Pfizer vaccine. They're both mRNA vaccines. Can you comment anything more, Dr. Sobieszczyk?
No, and they're quite, I guess the age groups in which they were studied, as Dr. Roykh sort of mentioned, the Pfizer vaccine studies included individuals above the age of 16. Moderna vaccine didn't include that population. So maybe it doesn't mean that it wouldn't work in those individuals, just in terms of kind of the authorization. There would be one difference. And then, the 95% efficacy versus 94.1%. Really, truly, I wouldn't call it sort of, substantive enough to make someone want to get one vaccine versus the other. One key difference, which is sort of more of a kind of an infrastructure, an important infrastructure and kind of public health issue, is how they are stored, right? So with the Pfizer vaccine, it has to be kept at minus 80 degrees, which can be, an important kind of limitation as we're trying to deploy these vaccines to places where there isn't as good a public health infrastructure, there aren't as many resources, and in terms of deploying it, in the context of local pharmacies like CVS, et cetera. So that's an important consideration, but it's not like does it work better, does it work less well, kind of a consideration.
It's a lot of logistics to navigate. I know the governor just recently announced that he will be permitting medical offices to carry the vaccine in the office, but it might take as long as 3 months to make that logistic possible. And again, because of that refrigeration requirement, there are some considerations to which vaccine would be available in the dental office or medical office versus in the hospital setting.
Okay. I have a question that came to me, and somebody wanted to know generally what is the efficacy of the flu vaccine, and I think it is a comparison efficacy of flu vaccine versus efficacy of COVID vaccine.
Yeah, that's a great question. That's why we're still blown. I mean, we've never had a vaccine that's against a respiratory virus that's more than 90% effective, let alone more than 60% effective, because the flu vaccine efficacy of it varies from year to year, depending on kind of how well we develop it and hit that, circulating strain. So it can be anywhere between 30 to 60%, on average 40%, some years 30%. So this is really, but it prevents severe illness, severe severe influenza illness. But for that reason, and because there's some, efficacy, the FDA continues to, of course, encourage its use. But another sort of reason why, when the FDA was looking kind of at emergency use authorization of other vaccines, it said, we want to have a vaccine that's at least 50% efficacious or effective in preventing illness, because we know from other respiratory infections that something that's in that range can be quite powerful and impactful for the individual and for the public health.
There's a technical question around the allergenic components of the vaccine. What is the lipid nanopackage derived from?
Yeah, so that's a great question. That's sort of one, sort of has stimulated a lot of discussion in terms of what is kind of in those lipid nanoparticles, and there are sort of very prosaic, some prosaic components, but many it's a PEG component of the vaccine that can be that is presumed to be the one that's sort of causing the allergies. So if there are individuals who've had an allergic reaction to COVID vaccine after the first dose, and an allergic reaction that happened within 4 hours of the administration of the vaccine, and we're talking about an allergic reaction like an anaphylactic reaction, then that would be possibly the only contraindication to receiving the second dose. Some individuals may, they can develop hives or a rash some days later after the administration of the vaccine. They should just report it when they present for the second dose. It's not a contraindication to receiving it. They may want to be monitored a little bit longer, but it's not a contraindication if it's like a delayed, hives, rash, etc. Reaction following the COVID vaccine.
I guess those are, very excellent questions. Something that we're managing here at Columbia is that, people hear from others when they get their vaccine that the arm is sore, or, they sort of are aware of the common side effects, and some of the staff and even faculty and others preemptively plan for not feeling well the day after and kind of arrange their lives around not feeling potentially at their top best. And so that's something that you might want to build into your practices, and that compassion and understanding that somebody might not be functioning very well, and whether you decide to give that employee the next day off preemptively, or being able to manage the potential absence the next day from the office is an important consideration. Requires good communication in advance.
Does anyone have any other, are we good? Does anyone have any other questions, comments, anything?
Yeah, maybe.
What I typed into the chat was that at midnight, they do release new appointments. I've checked it on several different days. So if your staff is having a problem, they just have to stay up late or set their alarms to get up at midnight to make that appointment, because there are appointments that are necessary, that are available rather. So that may stop some of the frustration.
It's a good tip.
Good tip. And I just saw if I may, just one question about a prior history of allergies to medications. Does that make somebody more susceptible to having an allergic reaction to the vaccine? And we haven't seen that. So for example, people have allergy maybe to sulfa drugs, Bactrim, or ACE inhibitors, etc. We have not seen any sort of increased susceptibility to an allergic reaction or a reaction to the COVID vaccine. And if I may just take one more, there is a question about should one checks an antibody level following vaccination. I think that was the question. Or just wait. So one thing just to point out is that, in kind of the there's no recommendation to check your antibody levels following vaccination. We know that majority, if not everybody, sort of makes an antibody response, and that's especially boosted and quite robust following the second dose. And depending on which vaccine it is, it can be seen anywhere between 7 to 14 days after the second dose. That's kind of that peak response. We don't recommend checking them kind of for clinical reasons. Only in a research setting. And I should mention that many of the antibody tests, the serology tests that are sort of done by LabCorp or clinical labs, they're not focusing on picking up the antibodies that are stimulated by the vaccine. So if you remember, sort of I was mentioning that the vaccine kind of stimulates production of antibodies against the protein S, or that spike protein. But the kind of many of the commercial tests just focus on detecting another type of antibody to the N protein of the coronavirus. So you may have a negative serology if you just go and get a kind of a routine antibody test. And I tell people, it doesn't mean that you didn't make those antibodies, just the test wasn't focusing on picking up the ones that are induced by the vaccine.
And I guess one last question is asthma a contraindication to taking the vaccine?
So that's a great question, and it is not. And in fact, because we know that people with respiratory lung diseases like asthma are at increased risk of getting more severe COVID, they're definitely encouraged to get vaccinated. And people with asthma were included in clinical trials, and we know that they tolerated the vaccine. It was safe for them, and it was just as effective or efficacious as in people with asthma or without asthma. So not a contraindication.
I apologize. I hear that the slides may not have been as visible as we wanted them early in the presentation. So we'll make sure to make them available to Susan and Diane, and she can circulate them. Our contact information is also on the slides, and I believe the presentation is also being recorded. Thank you so much for the opportunity, and I'm just so glad that Dr. Sobieszczyk was willing to join me. And of course, she's a technical expert, and we're very grateful for her knowledge and for what she had to share with the membership today.
Great, thank you.
Thank you both for being with us this afternoon. I know that we've all learned a lot and have answers to those crucial questions that we've been asked. So those questions are asked and answered. Thank you all for spending the time this afternoon to be with us, and we look forward to providing answers to other crucial questions as they occur. So ladies, thank you both for being with us. Thank you all. Have a great afternoon. And thank you, Susan, Diane, Susan, all of you for making this technically possible. Melissa for getting the Columbia community advised of what we were doing. And thank you all. What a nice way, what a nice way to spend a lunch. Thank you all.
Thank you, everybody.
Take care. Have a good day.
Thank you.
Bye-bye.
Bye.
Bye.
Thank you. Bye.
Thank you.